In Chapter 4, we're going to cover wound healing and repair. Now, when you think of wound healing, you got to divide it into its two major components, regeneration versus repair. Let's start with regeneration first. Basically, you're replacing the damaged tissue with cells of the same type. And whether an organ can regenerate itself or not is going to depend on what type of cell is injured. And for the boards, there are three major categories of cells. The first one is called labile cells. These are cells that have the ability to regenerate throughout life. A good example would be your epithelium, your skin, your GI tract. They're proliferating all the time. They can easily regenerate. The next category of cells is called the stabile cells. These cells can replicate, but usually they replicate at a very low level. A good example of this is somebody who has partial liver resection. You remove part of the liver, and the liver can regenerate itself over time. Okay, so it has the capacity. The last type of cell which the board loves to ask about are the permanent cells. These are cells that have a very limited ability to replicate. A good example are neurons and cardiac myocytes. Once they're gone for good. Now let's contrast regeneration with tissue repair. Tissue repair occurs when you've destroyed the architecture. You cannot regenerate any longer. So what does the body do? It replaces that area with a fibrous connective tissue scar. It uses what's called granulation tissue. Let me show you a nice example. Here's a photograph of the lower extremity of a patient who had a large wound, and this wound is now filling in with granulation tissue. It's undergoing repair. And I want you to notice that granulation tissue tends to have a very granular red appearance. Why does it look red? Well, one of the components of granulation tissue are capillaries. Let's look at the next photograph. This is a microscopic picture of this same lesion. And I want you to notice that granulation tissue has two components. The first component here are these structures. These are capillaries. They contain red blood cells. Here's another one. Here's another one. The other component are these elongated spindle-shaped cells. These are called fibroblasts. So anytime you think of granulation tissue, you got to think of capillaries and fibroblasts. Now, the role of the fibroblasts, they're actually synthetically active, and they're going to be laying down lots of collagen to give this wound some strength. And an important thing I want you to remember is that in granulation tissue, the first type of collagen that the fibroblast lays down is going to be type 3. Now, over time, the fibroblast will actually degrade the type 3 that it lays down, and then it will lay down type 1. The type 1 is the strongest of the collagens. So over time, you're going to form a well-healed scar, like in this photograph. Notice the difference between a scar and granulation tissue. A scar is mostly pink collagen. This is all nice, strong type 1 collagen. There are a few blood vessels left. There are a few fibroblasts left. But a scar is mostly collagen at the end stage. The next thing I would like to talk about are types of wound healing. There's primary versus secondary. For primary union, also known as healing by first intention, it usually occurs in wounds like a surgical incision, where you can take the two edges of the wound and approximate them very closely. You don't have to form a lot of granulation tissue, therefore you don't have a lot of scarring. That's healing by first intention. Healing by second intention occurs when you have large wounds, where there's a big gap that has to be filled in. And a good example of this is illustrated by this patient. This is a person who had a melanoma on their cheek, and you'll remember that the treatment of choice for melanoma is a wide surgical excision. So the surgeon went ahead and did a large resection of this area, and they left behind a very large defect. This defect is starting to fill in now with granulation tissue. Now, over time, what granulation tissue is going to do, it's going to contract, and it's going to pull the edges together. So this person is probably going to be left with quite a large scar as a result. Now, why does the wound contract? The board has asked in the past, what cell is responsible? And the answer is the myofibroblast. Remember I showed you a picture of those fibroblasts? Well, not only do they lay down collagen, but they can also take on contractile functions. When they do, we call them a myofibroblast. The next topic I'd like to discuss is aberrations in wound healing. In the past, on the exam, they've asked what is the most important factor that will delay wound healing? The answer is infection. It's very hard for your body to heal a wound until your body's cleared the infection first. What are some other factors? Well, if you've got a foreign body in the wound, if you have ischemia to that site, that's going to delay it. If you've got diabetes or vitamin C deficiency, those are all factors in delayed wound healing. The next two topics in your handout are examples of wound healing gone astray. The first one is a hypertrophic scar, the other is a keloid. You should know the difference between the two. Let me show you a photograph of a hypertrophic scar. This is a patient who's had cardiac surgery. We're looking at the chest wall. Here's the sternum, here's his sternal scar. Now what makes this a hypertrophic scar is that it's very protuberant. If you felt this area, it would actually be raised. And all a hypertrophic scar is excessive production of granulation tissue. Okay? And it's basically genetically determined. Some people are predisposed to developing these large scars. Let's contrast that with a keloid. A keloid is even more off the spectrum. A very small wound, like an ear piercing, will result in a large production of granulation tissue, which can actually form these large masses. Now, keloids have a genetic predisposition. They're more common in African American patients. They tend to occur in the earlobes, along the neck, the face, and sometimes the forearms as well. And they can often produce these very, very large masses. If you did a biopsy through this mass, you would see that it's a scar. It's mostly pink collagen. But the thing that makes it different is these large collagen bundles. These are all large bundles of type 3 collagen. Now, in keloids, remember that it's wound healing gone astray. In normal wound healing, it should start out as collagen type 3, and then over time, it should mature to collagen type 1. In keloids, that doesn't occur. It starts type 3, and for many years, it will remain type 3. And that's been a common board question. The last topic we need to cover in this chapter is we need to talk about the connective tissue components. Specifically, I want to focus on collagen. There are 14 different types. Do you need to know them all? The answer is no, but you do need to know the top 4. Let's start with type 1. It's the most common type. It's got the highest tensile strength, and it's found basically everywhere in the body. It's found in the skin, bone, tendon, and in most organs. Type 2 is found only really in cartilage and in vitreous humor. Type 3 collagen is found in granulation tissue, as I mentioned. It's also found in embryonic tissue, in the uterus, and in keloids. The last type is type 4. And type 4 you should know about because it occurs in basement membranes. And on the exam, they will commonly ask, what autoimmune disease produces antibodies directed against type 4 collagen? Of course, the answer is Goodpasture's disease. Last thing I want you to know in this chapter are basement membranes. Remember, they're composed of type 4 collagen, proteoglycans, laminin, fibronectin, and other components. Basement membrane also has a net negative charge, which is going to be very, very important in the kidney because it's going to play a role in filtration. That brings us to the end of Chapter 4, Wound Healing and Repair.